Aloha, and thank you for inviting me. It's a real privilege to be here and hear the tremendous work that's going on to try to address this disaster that has so affected this island. So I'll be talking mostly about the World Trade Center Health Registry, but I hope I don't have to repeat the events that I heard on 9/11. But it was an event that really impacted New York City as a whole, not just the area right around the World Trade Center towers. I arrived shortly after the disaster, and I participated in the scientific advisory committee that helped to design the study, and then I've been working on the response for the last 20 years, so it's been a very rewarding public health experience, but it has its challenges, and I think some of those you probably will be experiencing here, and hopefully I'll be able to point out some of the lessons that we learned. The event itself resulted in the evacuation of over 500,000 people from Lower Manhattan. So that's a larger evacuation than Dunkirk during World War II. So that was an amazing event, and it hopefully prevented some of the long-term consequences when people are able to evacuate. The registry itself is what we call a closed cohort. So that's a type of cohort that is defined beginning and an ending point for recruitment, as opposed to an open cohort, which is a registry or other cohort that's established at a certain starting point and then continues to recruit people. So this is an example of what we call a closed cohort. Reason why would you do a closed cohort? Well, it's mainly to enable research that actually can look at person years and assess risk. We also have focused on research, and I think that's an important point. Registries can have different purposes. Ours is focused on research on exposure, people who are exposed, so it's an example of an exposure registry. We also do surveillance, which involves periodic testing, usually both surveys as well as matching to external data sets like the National Death Index or cancer registries. We also do in-depth studies of subgroups of people who are exposed in different ways. We also serve as a platform for other researchers. So that's another important role of a registry, is to enable other researchers to be able to do studies of that same population. We provide recruitment, we provide ability to collect data and also share the data that we do collect. And we facilitate access to 9/11 related resources, such as the World Trade Center Health Program, which provides clinical services. So we're not a clinical service, but we actively refer our enrollees to get the clinical services they need. And you'll hear more about that from Dr. De La Hoz, who will be speaking shortly. The aims of the registry are to expand the knowledge about the health effects of a terrorist attack in the long term, looking also at things like gaps in healthcare, some of the things that you've heard about that your registry is beginning to really address. And we also respond to the health needs of enrollees. They tell us periodically they're either healthy or they're having health problems, and we try to refer them then to resources that can deal with those particular health problems. And we also maintain what we call the treatment referral program, which actively reaches out to the enrollees who have not yet signed up for the World Trade Center Health Program. And we also maintain this as a public health resource for other research on things like future disaster preparedness. We've done intervention studies to try to see if we can impact disaster preparedness in New York City. Creation of the registry was in 2002, not too long after the disaster, but took about 2 years to get the Institutional Review Board approvals. So we really didn't start accumulating enrollees until 2003. And we did recruitment over about almost a 2-year period. Eligible people were identified, and that's the other interesting lesson is how do you identify who's eligible? We identified it through a geographic boundary that was set up by the Federal Emergency Management Agency. But in retrospect, that was not a big enough boundary, and it caused a lot of controversy because people felt they were across the street from the boundary. They were affected. For example, people in Brooklyn had a lot of dust that crossed over to be a problem, and those people were not eligible for our registry. So that's a lesson that had to be learned, and then the World Trade Center Health Program expanded the boundaries so that people get treatment who would not have been eligible for our registry. So that's a good lesson. Boundary setting is a very important step and needs to involve the community, which we didn't do as effectively as would have been desired. We did a recruitment through many ways. We did recruitment through door-to-door, passing out information. We had lists of hundreds of thousands of people who worked in different buildings in lower Manhattan. We also did a website that people could sign up and pre-enroll. And then as a result, we were able to recruit over 71,000 people out of about 400,000 we thought were eligible. So is that a good representative sample? So that's another question, is how representative, if whatever sample we get, is always a question, is it representative? And so we've had to do a fair amount of studies to try to see, is it representative? Here are the eligibility groups that we identified, beginning with the building residents, people who are actually in the Twin Towers, or in passerbys. That's our largest group. We had coverage. Coverage is the other way you can assess a registry. How many people out of the total that are eligible actually sign up. In this case, the coverage for people who are passersby and occupants of the local buildings was with even collecting 43,000 people, that turns out to be about a 12% coverage. We did a little better with the rescue and recovery workers, but mainly because we could reach out to their unions and other ways we could identify them. And we have a coverage of about 1/3 of that population. And then there's, of course, the residents themselves who lived in the area. And we've estimated based on the census that we had about a 25% coverage, which is actually not too bad. And the hardest group, of course, is children. And the children have to be reached through their parents. And we went through efforts to try to get the schools to do more outreach for us, because we tried to reach all the students that were in the lower Manhattan area. Some of them didn't live in lower Manhattan. We've only had about 17% coverage of the children. And that's been an ongoing debate and criticism of our registry, that we were not able to reach more children. So there now is an effort to create a new child registry. 20 years later, it's going to be a tough. We did a pilot to see how many people would actually sign up. It's a tough do. So if you can recruit the children in the beginning, that's another lesson that we learned the hard way. Try to recruit the children. And it's hard to convince parents to sometimes sign up their children for something that's going to remind them of a traumatic event that occurred to their parents and to them. So I really underline the importance of that beginning of a registry, trying to get the children as best you can. World Trade Center Health Registry is a little bit unique in the sense we have enrollees from all 50 states and 15 different countries. People came to volunteer, people showed up working for other agencies, and so they're all spread out over the whole country, so it makes it a challenge keeping up to where they are at all the times that we do outreach. We have diverse subgroups. There are a lot of subgroups that you would expect: the rescue and recovery workers, people who worked on the debris pile, for example, people in the police department, the fire department. But there's a group called the volunteers, and I think that's another area that you're, I think, focusing on. And really, I urge you to focus on the volunteers. The volunteers in our studies turned out to be the highest affected people. So many of them were volunteers that just showed up out of the goodness of their hearts. But they were not trained, they didn't have adequate protective equipment. So they turned out to be the most affected people. But it's a problem now trying to get them to join the World Trade Center Health Program. They're the least currently members of the World Trade Center Health Program. And why is that? They're hard to reach. We don't necessarily know who they were. They didn't come and sign a registry. They didn't necessarily let anybody know what they did. So I think, again, volunteers are a very important group to focus on. We also have the evacuees, that people evacuated from the homes living near the site. But even though it's a mandatory evacuation, 1/3 of people living in close proximity didn't evacuate. Who doesn't evacuate? That's another important group. I just did a study just published on who didn't evacuate. And that group would be, as you probably expect, people with lower income, didn't have a car, didn't have a way to evacuate, had pets. So your pets point is a very important one. People don't evacuate if they can't take their pets. And people also may not have had contact because of language. They didn't have information about the evacuation. So there's a lot of reasons sometimes that people don't evacuate. And that's another important lesson, is try to look at the people who were not able to evacuate, because they tend to be the people that have maybe longer health, or more important health problems. The range of exposures, people are witnesses, of course, to very traumatic events. I'm sure that happened here. And that's the largest group that we have in our registry. People are caught in the dust and debris and the smoke. I think that's the second largest group, which you have here. And also people who were evacuated, people who worked on the debris pile, which occurred over about a 9-month period. So it was a very long, that was a chronic exposure, not an acute one-time exposure. We've done surveys. We've done 5 follow-up surveys since then, about 3 to 4 years. Every survey, so we started out by doing separate surveys of children and adolescents. We've done special surveys looking at asthma and respiratory problems. And we're planning a 6th survey in the next month or two. We'll be distributing the 6th survey. So it's a long-term commitment. You know, that's the other part of the exposure registry, is that it means that we need to follow people for long periods. And it's a challenge to get the funding to do that. I think that's the other part, the constant effort to try to raise the fund. And you know, there've been a lot of groups trying to work on making sure this registry doesn't disappear. A lot of these types of registries last about 10 years, and then there's a dwindling of interest. So that's a big challenge, I think, to maintain the interest in cooperation and participation. We've done particular studies looking at some of the emerging conditions. We did a study of something called sarcoidosis, which is a relatively rare lung disease, but it was noted in the fire department that there was an increase in this kind of sarcoidosis among the firefighters. So that way stimulated us to do a broader study, and we followed up all the medical records of people who reported they had sarcoidosis and proved that it did seem to have an association with exposure, but it takes years to develop. We've done a series of respiratory studies. Autoimmune disease is another issue that was raised by the community. These are rheumatoid arthritis, lupus, and other autoimmune diseases were not something we thought of in the beginning, but it's something that emerged as the community kind of lets us know. These are things that they're concerned about. So we then went back and started looking at our own cases, and indeed there was evidence that there was some association with exposure, particularly for firefighters. We also, we put our data on the web. We have a de-identified data set. Every survey is put up on the web. And our enrollees are very sharp, and they tend to take the data and analyze it and say, you're missing something. So they noticed that we reported something on hearing loss in our first survey, and then they said, well, what's happening with hearing loss? And they actually analyzed our data and said, you better look closely at hearing loss. And so we did a partnership study with the fire department, looking at audiograms of the firefighters, and indeed we showed that people exposed to the collapse of the Twin Towers are exposed to incredible noise. So it's not something that people thought of in the initial phase. We never thought of hearing loss as a consequence, but I wonder if that's something that with fires, you have an incredible sound. If you've ever been in a forest fire, it's a very intense sound because of the, I don't know how it exactly creates, but it's an important thing to look at hearing loss in that, especially firefighters or other people who are up close and near the fire. There's something called multiple chemical sensitivity, which is a rare condition where people may be exposed to a high-level exposure in the beginning, maybe a spill or paint or things like high levels of chemicals in a workplace, and then become sensitized to maybe other lower-level exposures in daily life. And so our enrollees, our community advisory committee asked us, did that happen with the World Trade Center? And we didn't know. We never asked the question. So we did a follow-up study, and then we had people answering, yeah, some of them were diagnosed by their physician, and we'd done a follow-up study to see if they have chemical intolerance, which is a very rare condition, not very well known by doctors. So it's something that we can answer the question with the community. Turns out our rate of multiple chemical sensitivity doesn't seem to be greater than the general population, but at least now we have some answers to that question. And finally, we're actually studying post-traumatic growth. I don't know if any of you have ever heard of this. Maybe psychologists in the audience might recognize it, but it's a condition that people with post-traumatic stress may change their life in a very significant way. You've been through a disaster, you look back on your life and say, what can I do differently? Maybe take advantage of the fact I lived, I'm alive. And people change, sometimes in a positive way, even though they've been traumatized and have post-traumatic stress. So we're currently doing a study of post-traumatic growth to see if there are some positive things. Our enrollees complained. We've always asked, every survey, ask all the negative things. But what about the resilience? What do people do to survive and thrive, even though they've been through this terrible disaster? So those are important things to consider. It's not just the negatives, but ask about how people are coping and what they do. Sometimes we can learn lessons from this disaster to help people cope and prepare. We've done quite a number of studies. We published 180 or so publications since 20 years ago. And these are just a small sample of what we published. We've been focused most recently on cardiovascular disease because that's an area that hasn't been well studied and is not currently part of the World Trade Center Health Program covered conditions. So there are things that we'll learn over the 20 years that point to things that maybe are gaps and things that might need to be covered in the future. Quality of life is another major impact. We do collaborate with other people mostly in the areas of cancer and mortality. We collaborated with fire department and the hospitals in the area have been treating many people from this disaster. And we're developing registry manuscripts with partnerships with universities, like the University of Hawaii is playing a major role in this disaster. And I think we try to tap into the academic community so they can contribute. We do matching. It's another area that helps increase the credibility of our self-reported surveys, because we can match and looking at mortality, particularly National Death Index, vital records. SPARCS is our hospitalization registry. So I'm not sure if that data is available here, but that's something that can help fill in the gaps when you have self-reported data, which that's what we collect. We also do state cancer registry matches, and we also have planned looks at things like Social Security disability, and Medicare, Medi-Cal, or Medicare, and there's a renal database that we're going to look at. We've never looked at kidney disease. And of course, the U.S. Census has data that you can use to compare. But that's another criticism of our registry. We don't have a comparison group. That's something we thought about in the beginning, but we really didn't have the funding to create another registry of people not exposed. So that's another area that you have to think about. Who's going to be your comparison group? Of course, the National Health Interview Survey and other national surveys can be used, but it doesn't represent Hawaii necessarily. You may have good data on some comparison groups from other islands, but those are important for scientific point of view. We also serve as a platform for external researchers that can apply to us and access our enrollees. So that's a good way to broaden, because we're a limited number of staff. We've had dozens of researchers use our registry to try to ask questions that we weren't able to ask. Things like prolonged grief. It's going to be an issue here. When you have so many people who died, those people affect many people in the community. And we're looking to try to look at the long-term effects of prolonged grief, for example. We did a lot of studies on the PTSD in the police. Police had the lowest rate of PTSD compared to other population, but we suspected that it was because they weren't able to report it because they might lose their gun. If you report things like PTSD, New York City Health Department, New York City Police Department, they were at risk of losing their occupation. So we've done repeated studies among the police to see, and of course now they're mostly retired, so maybe they're more willing to come forward and talk about the real consequences of what they experienced. We also share experiences with other disasters. We've worked with South Korea on their ferry disaster, and Horizon oil spill in Texas. Flint, Michigan, we'll hear more about this week. We've done a work with Israeli trauma registry, Maui. We've started working with you, and I think that it's an example of trying to learn the lessons that we all are learning and sharing that information with other disasters. We've established something called the CLEAR Forum. It's a forum to share best practices in keeping a registry alive. And that's something that it's been very, very, very successful. We have about 13 longitudinal studies that are now participating in the CLEAR Forum, including the Nurses' Health Study, the Framingham Health Study, the lead registry. There's a VA study of burn pits. You may have heard about that in Iraq. And then also there's the Maui your health study is now part of the CLEAR Forum. So there's another way we can learn from you, and you can learn from us. I think that's so important because this is not a everyday occurrence, but it does occur enough, and we're going to see more with climate change. We're going to see more climate-related disasters in the future, and I think we can all learn how to do this better. And we try to respond to our enrollees, and I think that's another lesson. That you're already doing a tremendous job of trying to link up your enrollees to services. I think that's something that we were not initially designed for, but it is a very important part of being a registry is listening to your enrollees and trying to figure out what are the things that are missing that they could be benefiting from. We try to keep people engaged, and that's a challenge, I think, for any registry. And we do have periodic newsletters. We have a website with our findings. It has all our results. We do videos and testimonials. That's one of the most inspiring things to hear from people telling their stories. And we're right now there's something called found poetry, which is kind of something I'd never heard of, but using people's stories, creating poems that can then help inspire other people to tell their stories. So that's something that I'm sure you'll have incredible stories as part of the registry's legacy, and using those in a way to inspire people to be prepared for future events that might similarly affect them. So as I said, we have a website that has a lot of our materials as well as our data, and feel free to take a look at it and see what we've tried to do. We're trying to develop a dashboard. You've done a dashboard. We're still working, trying to get permission to do a dashboard. So we're going to be learning from you how to do that. And then we've tried to do research and reach out in meetings. And I think that's the other thing that we try to do, is share our results in publications, but also speaking. So I really thank you again for your attention. And again, we look forward to continuing to be part of your efforts, as well as you being inspiration for us. Thank you.
Yeah, I think we have like 3 minutes if folks have questions. Over there.
Good morning. Thank you so much for doing this. My name is Catherine Perkle. I'm a professor in public health and also under Dr. Weldon, the scientific director of the Red Hill Registry. I had 2 questions. I'll try to be brief because I know we have 3 minutes. I would love it if you could expand or tell us a little bit more about the tools you use to recruit and retain registry participants that were geographically dispersed. You said you have people from 15 different countries and across the United States. So I'd really like to hear a little bit more about that. But I have a second question too, and I'd like to know a little bit more about what you did with the multiple chemical sensitivity, but I'll come back to that if we have time.
Yeah, it is a challenge to reach people that were not necessarily part of a business, or we had hundreds of thousands of people who were just in the area. We don't have their names. We have no way of knowing who they were. So we did a lot of public service announcements, and we did a lot of kind of outreach to people that might know of somebody. So it was a lot of that kind of personal outreach. We had to do door to door in the neighborhood. We went to every firehouse. I personally went to firehouses. We went to every roll call for the police department. And we tried to reach out to the schools. The school district didn't really cooperate as much as we would have liked, so that's why our children representative is, it's only 17%. So I think there are things that you can do. It takes a lot of imagination to try to again reach all the people that could have been affected. Here you also had probably people that were tourists, people that you don't even know who they were. How are you going to maybe involve them beyond the people who are in the neighborhood? So I think that that is one of the biggest challenges of this kind of disaster that's unplanned, unpredictable. How do you actually keep track of people, and then how do you let them know how do you reach people that are in many countries? That was not an easy feat, but I think the combination of all these things is what we had to do, and took quite a long time to try to put it all together. But many people actually, after we closed the registry, wanted to join. So it's a good thing that the World Trade Center Health Program was established about 8 years later. But people did want to join. That's the only unfortunate thing about a closed registry, is we closed the registry after a certain period. In terms of multiple chemical sensitivity, it's a very controversial topic. Many doctors think it's not really a real condition, but we listened to that community voice, and we did work with a researcher who designed a survey instrument that we then distributed to a sample of our enrollees, 2,000 of them, just to get an idea, is this something that came out of the World Trade Center? And our preliminary analysis suggests there are people who are having that problem as a result of their exposure. It's not a large number, which we're very thankful for.
Okay, so that was my question, is you were diagnosing, or you were ascertaining it through a questionnaire and not through the doctor diagnoses?
We use both.
You use both,
Mm-hmm.
okay. And
the
question,
doctors mostly don't know what this is. So.
And are you able to share that questionnaire? I think for us with the jet fuel exposures, especially since we believe it might be concomitant with other exposures,
Sure.
this
yeah.
is something that seems to be perhaps an issue or starting to come up a little bit in the community. It'd be lovely if you had a questionnaire you were able to share with us.
We do, yeah, well, I'm glad to share it.
Thank you.
Yeah, it's, again, an area that is not very well researched. So if you can look at it and help understand it better, that'd be a big help for future disasters.
Thank you so much, James.